The Nurse Theorists, Portraits of Excellence. In this edition, we feature Dr. Myra Levine.
Well, I was born in Chicago. I was the oldest sister all my life. I've been big sister. I have a brother who is 2.5 years younger than I and a sister who is 8 years younger than I. And we're very close, even though we're very far apart geographically. We were a very close-knit family. My father was a hardware man, and I have often very proudly said that I'm a hardware man's daughter. He was a really great guy. He was a big, gruff man with a red mustache, you know, and he was very fond of me. I know he was, and I remember him with great fondness. He was ill, but you know, in spite of, and hospitalized frequently and often quite ill. And I suppose that had a great deal to do with the interest I had in nursing. I knew more about gastrointestinal surgery and treatment than most kids did by the time I was 12 years old. And my mother was a terrific lady who, at the age of 70, was still a one-girl office. And she was really something special. She loved nurses and was often the hostess for half of the class at Cook County School of Nursing. But she knew them all, and they all knew her. I went to elementary schools in Chicago, and to high school in Chicago, and to the University of Chicago, which I think had a tremendous influence on me. No one, I think, who ever went to the University of Chicago as an undergraduate student since the days of Robert Maynard Hutchins was untouched by that education. At the end of my second year at the University of Chicago, it became quite apparent that I couldn't afford it any further. And I wanted to be, I guess I started off wanting to be a doctor. And I had made some inquiries about it, and they had been rather discouraging, largely on the basis of, first of all, my religion, and secondly, that I was a woman. And in those days, there were very few individuals with those two handicaps that were admitted. And so I'd had an emergency appendectomy in my last year in high school, and it was my first contact with nurses on a one-on-one basis, and I fell in love with them. And I wanted very much to go into nursing. Well, I have always been a med-surg nurse. I think that's the very heart and soul of nursing. There are a lot of things that, you know, that came out of my experience at Cook County that I'll never forget. It's a remarkable institution. All of the rooms in the Cook County School of Nursing were private rooms. I'd never had that before. I'd always shared it with my sister. And the other thing was that I was terrified, you know, because I'd never lived away from home either. And here I was, you know, in County Hospital about to begin this great adventure. But it was exciting too, you know, and there was a business of meeting all the new people.
I first heard about her when I went to work at Cook County School of Nursing, when I first came to Chicago from the farm. And apparently she had just left. She'd been teaching there as a science instructor, and I was coming as an assistant science instructor. But the students whom I taught had been taught by Myra, and they talked about her all the time. They told me how marvelous she was, what a wonderful teacher she was. So without ever having met her, I decided I wanted to be just like her. I've known her for 20-some years. She's been extremely generous and helpful to me in a number of ways. She's fearless, but maybe most people know that. I don't know myself what that costs her sometimes, but she is a very highly principled woman. She decides what's right in a situation, and then she does it.
The reason I think Myra is so committed to the practicing nurse is because she's so committed to what happens to patients. And I think she's so concerned about the quality of care and the quality of life that commits her to the people who give care directly. And I think she's just maintained that all throughout her whole academic career.
She's a remarkable woman. And you probably know that or you wouldn't be here. But I was first impressed by her articulateness, that she could talk and make sense, and it sounded beautiful. And I love that kind of speaking ability. There was no false hesitation, long delays, or what have you.
We retired together, you know. We had a reception together. I wouldn't have had it any other way. I don't know about Ed. He really, you know, had a good deal of contact with the nurses at the University College of Nursing. Many of them had taken courses with him over time. So it was appropriate and wonderful. Well, being a faculty member, of course, you know, was the one thing that I always wanted. I was never interested in anything except teaching.
In an interview on the University of Illinois at Chicago campus, Dr. Levine discussed her conservation model with Dr. Jacqueline Fawcett.
It's been 20 years since your article, The 4 Conservation Principles of Nursing, was published. I wonder if you could explain your motivation for writing that work.
I was looking for a way of teaching medical surgical nursing that would fit into 3 quarters and at the same time cover the most important concepts. And I really was looking for generalization. I had a fairly strong physical science background in college before I even went into nursing. And the conservation of energy as a natural law was simply something I accepted and knew. My feeling about it was that if it was something that was absolutely required for understanding all animate and inanimate behavior in the universe, that it ought to have something to do with nursing as well. And so for a while we talked about conservation of energy with my friends. It was a relatively easy thing to do because so much of what nursing activity involved really was to deal with, in some way, controlling the energy resource of the patient. You fed them and you saw that they had adequate fluids and you were concerned about their activity and so on. And it fit nursing. And for a long time I could not figure out what went with it, although I had a deep conviction that something must have. And then it just gradually fell into place. That what we were talking about was not just the energy, but also the structural integrity of the individual. We were talking about him as an individual. We were talking about him as a member of a society. And that all of those things were the substance of what you talked about when you taught nursing. And so essentially that's what I wanted. I wanted a way to teach nurses how to nurse. And that's what I was looking for.
Then what I think you're saying is that looking at the person as a person is dealt with in the principle of personal integrity, and the person as a social being is dealt with in the principle of social integrity.
Right.
What puzzles are left over in the 4 conservation principles? Puzzles in the sense of Thomas Kuhn's use of the word as paradigm puzzles. What's left over? What's not answered by the 4 conservation principles?
Well, I don't know. I look at the context of the sense of solving a puzzle in relationship to nursing care as being recreated in every single instance in which a nurse and a patient come into contact with each other in some professional context, some sense. And every time it happens, it's a puzzle. And the answers, therefore, must be individualized. That there are certain kinds of emphatic needs in one situation that may be less important in another and so forth. And also that those things shift through the course of a relationship with a caregiver. That the patient doesn't stay the same, he changes constantly. And that constant change then has to be reflected somehow with the nurses is planning with him and in his interests.
Do you think your ideas will endure? Will what you've taught your students be passed down from those people who are now nurses to their students or the other nurses with whom they come into contact?
I think the proof is in the pudding. I mean, the proof is in the excellent clinical specialists all over the state of Illinois who have assumed leadership roles in oncology nursing here. And in all of those people who went through the program when I was privileged to be with it at Loyola into various areas of clinical specialization, they are excellent nurses, they are excellent researchers, they were marvelous teachers, and I was privileged to be part of their education. Yeah, it stays with them. It stays with them because they recognize in themselves the things that are worthwhile. And that's what made them such good nurses.
You're going to be publishing a chapter in Conceptual Models for Nursing Practice, Edition 3, edited by Joan Real-Siska. In that chapter, which I'm very privileged that you've shared with me pre-publication, you've obviously expanded on and elaborated on your ideas of the conservation principles and the other elements of your conceptual model. I wonder if you could share that with us now.
I'd like to suggest that there's in it some insight into what conservation really means. The original notion was that it came from a Latin word, conservatio, which meant to keep together. And it was that keep together sense of retaining wholeness that was so attractive to me. But recently, within the last several years at least, I have been feeling that that was never a sufficient explanation for what was really happening. It wasn't a process that I was describing. It was like an end result. This is what happens, and I began to wonder about the process itself. And I liken it more than anything else to the way in which a thermostat works. When the thermostat is set at a precise figure, and the ambient temperature in the room is at that figure, nothing happens. When the temperature falls, the heating unit is kicked into operation. And as it heats the room, it uses energy. When the set figure is returned, it turns off. And that is the essence of what conservation is. It is the way in which physiological and other functions, I think, sociological, psychological, other functions, have become adapted to perform in the most frugal, the most economic, the most energy-sparing way that's possible. Now, when you think about that, you realize that so much of normal physiology, maybe all of it, and so much of pathophysiology is reflected in that. That when you talk about something being conserved, what you're saying is that you save it in some way from stressors, from unusual challenges from the environment, from changes within itself. Now that applies to everyone, the nurse and the patient.
What other changes or elaborations on the conservation principles and other elements of your model are reflected in your current work?
Well, I think one of the things that I did was to take another look at adaptation as a process. Dubas has said that the word is used in such colloquial ways that almost anybody can make it mean anything they want it to mean, and it's very difficult to define a term like that. And it seemed to me then that it was being used in very poetic ways by many people. It's a term that needs definition, in spite of the fact that it is very difficult to be precise about it. It needs definition, and so it occurred to me that you can define it in terms of the way in which it functions, in the sense. You're talking about a process. What is this process? How does it work? And that out of that would come what it means. Now, the very first thing about adaptation is that it is, beyond question, a historical process. We're talking about our ability to deal with changing temperatures and so on and so on. Those are all adaptations that have come through time in an evolutionary pattern over a long period of time. And I want to emphasize when I talk about this that it seems to be physiologically oriented, but it is behavioral as well. It's both. And it's both things at the same time. It's not this happens and then this happens, or that these two things happen next to each other. They're one thing. And they're components of the same thing. So that in the sense of history, there's a lot about our history in adaptation we don't even understand.
Your idea of physiological and behavior as one and the same seems to be the essence of wholeness and of integrity. Is that correct?
Right. And I really mean that. It is very difficult to break down a body of knowledge and a discipline and say we're going to study this in its large context. You have to take it piece by piece and look at it, but you also have to have a way of putting it back together again.
And the conservation principles
I think
do
they
that.
do. I think they do.
You've said that research guided by your conceptual model should encompass all 4 conservation principles. Now, if a student or a faculty member or whomever would like to, for example, develop some sort of an instrument to measure a conservation principle, would that be a violation of your idea of the model?
No, because you see, and to say that all 4 are involved is not to say that in doing research one doesn't very carefully select a proposition that is manageable, and that somehow or other then added to the information increases and enlarges upon the original notion. Over these 20 years, I have seen all kinds of ways in which the conservation principle has been interpreted, some of which I agreed with and some of which I did not. But I have said repeatedly to students over the same period of time, I want them to use it in a way that somehow or other makes sense to them. It's their learning process that's important. And if, in fact, they use it in a way which I would object to, that is to say, I wouldn't have done it that way, it doesn't make any difference. As long as they have learned from that experience what it was they were pursuing. It's happened over and over again.
What I hear you saying is that the 4 conservation principles are applicable to all people, wherever they are, whatever their situation is.
That's right. And you cannot be a member of the human race and somehow isolate yourself from the rules that guard the way in which the body functions and the way in which behavior is promoted and so on. It just doesn't make any sense to me. And that anyone would even have insisted on this.
You see the 4 conservation principles being used then wherever nursing takes place.
Wherever nursing takes place. Nursing takes place everywhere. As my husband testified yesterday, it even took place in our own home. It takes place wherever there is an individual, and I think this is an important thing. An individual who needs to be taken care of to some degree. It may be minimal, it may be rather intensive. But the point is that whether we like it or not, there are times in our lives when we enter into dependency stages. That's all. And we're very fortunate if at that same time there's somebody standing by who is willing to invest their skill, their knowledge, their caring, their compassion, their interest, whatever, into helping us out of that dependency. That's the part that gets lost.
And that's why you use patient.
And that's why I use patient, because to me it is a very temporary state of affairs. Patients are not my clients, as Galen pointed out so beautifully in a paper he gave here a couple of years ago. Clients are followers. I don't want patients following me. I want those people to be able to make as many decisions in their own behalf as they possibly can. I want to give them the best information I have. I want to give them the best kind of hands-on care I can whenever they need it. And then I don't want them to walk away from me I want them to be free, independent, mobile human beings, not any longer patients. And I think looking for other words to describe that is just confusing us.
Could you elaborate on your ideas about adaptation?
Adaptation, first of all, then has historicity, as I said earlier. The second thing that it has is specificity. It is specific in the sense that it is called into action by a given challenge. And as, for example, on very hot, humid days, we have a variety of ways in which we physiologically and behaviorally respond to this that is completely different from the way in which we respond to a very cold day. There is a very high specific response. Now, what that means, in effect, is that there are certain kinds of reactions that one can anticipate will take place. But you cannot be certain, even so, because there are so many individuals and so many different ways in which individuals respond to given situations. But I think that it is important to keep in mind that certain adaptations are quite specific. The third thing is the area of redundancy. This is an area I've played around with for a long time now, and finally I think I've put it in place. At least I feel comfortable at the moment about it. One of the most remarkable things about the living species is the fact that they have a number of levels of response that permit them to survive, not just survive. I don't really mean to survive. That permit them to confront the reality of their environment and ways that in somehow maintain their well-being. What we see in the redundant systems in the body are fail-safe systems. Maintain the pH of the blood, for example, which is a remarkable system of systems, so that there is a fail-safe way. If one system does not completely adapt the individual to the challenge, there's a second one that can take over. And I think that whole notion of redundant system, a fail-safe system, is a function of adaptation.
But what happens if I think that the behavior is inappropriate and you think it's appropriate? Are we really dealing here with value systems?
The criteria of success, of course, is satisfactory survival. If confronting a situation, you are able to deal with it in some fashion, then obviously that's worked. If one were to make a sort of a generic definition of adaptation, it would have to be, and interestingly enough, it comes straight out of the language from which it is derived, is how does it fit? And I like that. I think it isn't simply congruence, but fit. I have some shoes which are congruent with my feet, but some of them fit, and those are the ones I like to wear. And I think that the issue is a difficulty of using language that has so many poetic applications that when you want to talk about it in a specific way that has to deal with decisions that a nurse may have to make and so on, it's very difficult to do it because we don't have that kind of clarity of definition. But adaptation is the best fit. That's what it is.
What's next for you?
Well, I really can't answer that because first of all, I'm going into retirement. And anyone who tells you that you go into it smiling sweetly and happy and is not telling you the truth. I am very much concerned, however, with some of the problems of health delivery in elderly people, because I've suffered some of them personally. And whether or not that means that I'm going to be doing any further work with the theory or not, I don't know. I'm a little astonished that I even call it a theory, because I've never believed that it was. I think I've come closer to it now than I have ever been, but I don't really think it is.
I call it a conceptual model.
Yeah, it is a conceptual model, and I'm satisfied for it to be that. I hope that somehow or other all those young people who were calling me up when I had an office number will find me at home and call me and will talk to me and will write to me and will send me blank tapes with many questions so that I can still feel that I'm participating in it. Because I once did a little book which the Illinois Nurse Association published called Return to Nursing. It was at a time when we were trying to get as many nurses back into nursing as we could. And the preface to that book I said that a nurse is always a nurse. And I guess I'm always going to be one, whether I'm retired or not.
I'm sure that you'll be involved in conferences here and abroad and in writing. What I hope you would do is write more for us on therapeutic intention and redundancy.
Yes, I'd like to play with that some more. I'm still
We're
interested
still
in it.
left hanging on that. We have a little bit more now than we did when you talked about them in 1978.
Well, I feel better about redundancy than I did before. The therapeutic intention I'm still not sure about. I'm just not sure about it. And so I suppose as long as there are open questions, there are all kinds of roads to follow.
I'd like to thank you so very much for sharing your ideas and your work with us. It's been an honor for me to be able to talk to you, and I know that the viewers are going to be thrilled with your comments. Thank you so much.
Thank you very much. It's been a real privilege to be able to talk to you.
Well, I would have told you that she is just a really marvelous person. She's very perceptive and very understanding and giving, and that's very important, and particularly in her career, but also with relationships with people, and that's what this is about, getting along with other people and taking care of people, and I'm sure that she's excelled in her profession because of those skills that she has, and they're natural for her.
Whenever I want to help nurses to understand nursing and what it's all about, if Myra's in the area, I want Myra to talk with them. Not only at Cook County Hospital, where we work together, but also at Hines Veterans Administration. She was our first speaker when we began to do nursing rounds in relation to the care of patients, and eloquently discussed the holistic concept, conservation principles, and what it meant to the nurse at the bedside.
It's not simply knowing a lot of things, but it's a way of knowing things. If you keep looking hard enough and long enough, you're going to find out what it is you want to know. And that you just can't be in a hurry about the things that you learn.